So let me give you some examples of what hospitals are doing very quickly. In Missouri, Truman Medical Centers in Kansas City is led by our immediate past chairman, John Bluford. TMC is a safety net hospital that serves a highly diverse community and one of those rare hospitals in our membership that manages and operates a county health department. They also have an active employee wellness program, and some of their novel approaches are coming out of their own employee population health efforts. They think of employees, most of whom are part of the community they serve or live in the community they serve, as ambassadors of health. So they provide a variety of continuing education and life skill classes for staff and their families, because they're all dependents on their health plan, even down to and including, when it makes sense, tutoring for the kids. They hold a farmer's market so that staff in the community have a convenient source of fresh fruits and vegetables in a community setting that does not provide many food store options. And their employee program is aimed at providing better support for people with multiple chronic diseases and has worked so well that they're expanding it out to their patients. So they're learning closest to home first. In Louisiana, the Department of Health and Hospitals is partnering with the Louisiana Hospital Association, the State Medical Society, and the state's chapter of the American College of Obstetricians and Gynecologists to encourage Louisiana's birthing hospitals to implement policies that end non-medically indicated inductions before 39 weeks gestation. This helps to avoid, obviously, in-hospital complications for the infant, but it also helps to avoid and stave off and maybe forever reduce complications out and costs out in the community for the kids, their families, and the call that they have to make sometimes on other community resources, social services, your services, schools, and others when these kids have special needs. One of the leaders in that is our current chair, Terry Fontenot, who's president of Women's Health, a large birthing hospital in Baton Rouge. In Washington State, the Choice Regional Health Network includes rural and urban hospitals, practitioners, public health agencies, clinics, community health centers, behavioral health providers, all focused on access to care, quality improvement, collaboration, community development, and joint advocacy. And in Iowa, the Center for Healthy Communities has created the Department of Iowa Health in their Des Moines region. The center links resources with identified community needs, and key partners there include the Polk and Dallas County Health Departments and the United Way. So these are just a few examples, but we all know that the Affordable Care Act will speed up this process as well. The law has attempted to expand coverage for a range of prevention and wellness services and encourages partnerships between hospitals and other community health organizations. And this will and must continue regardless of what happens with the Supreme Court decision. Accountable care organizations, patient-centered medical homes, workplace wellness programs, community transformation grants are just some of the ways that hospitals, public health, and others will work together on new and innovative ways to improve health and safeguard health of our communities. Now, the AHA supported and continues to support the Affordable Care Act, primarily for 32 million reasons, those people who would receive coverage, but also because it would move us forward in advancing a vision of health. And the AHA's corporate vision has been of health for the last 15 years. It's a vision of a healthy society, a society of healthy communities where all individuals achieve their highest potential for health. We haven't put our own vision statement in hospital terms. We've always put them in community and health terms. And off of that, we built something called Health for Life, which was our reform framework that guided us through the debate in 2008, 9, 10. And it focuses on 5 key elements. A focus on wellness, actually building a business case for wellness for hospitals and other providers. Coverage for all, paid for by all, getting everybody in the pool and sharing in our cost of that to the extent that we each can. Building more efficient and affordable care systems, providing the highest quality of care, and providing the best information. Best information for patients, for practitioners, but also in a transparent way for communities at large. It also has a list of ideas for change, and I'd like to go over some of them that really do focus in on the issue of public health and community health. We believe that the public health system must be appropriately funded and supported to ensure that a focus on wellness and prevention touches all individuals, regardless of their insurance or employment status through the medical model, and to ensure that communities have sufficient resources to protect and improve the public's health. We'd like to see modernization on your side of the health equation, as with the patient side as well, particularly around information systems, so that we can build and connect our respective information systems to share the most helpful and most current data. We'd like to see expansion of public health programming on the underlying causes of health, like smoking, substance abuse, lipid control, lack of exercise, things that only become medical problems farther down the road. And we think it's important to identify and integrate the critical interfaces between public health and the acute care community to build more efficient and effective systems overall. Other ideas for change concerning healthy pregnancies and newborns, investing in school and community-based health, creating an objective, trusted source of consumer health information and education, providing support, coaching, and incentives to change unhealthy behaviors and encourage healthy choices are all important and are all upstream from the medical care system that we now provide and a realm that we know we need to expand into. So we're all in this together. Yes, both the medical system and the public health system, and we're needed if we are to generate that epidemic of health, or if we're ever to achieve truly accountable health communities. And this is where research can play a big, big part. Not just public health research, and not just medical research, but collaborative health research. We need to know the most effective collaborative models to pursue, the right timing and mix of population and patient health interventions, the most effective ways to advocate for greater personal and community responsibility, side by side with the right system changes and accountability mechanisms, the right measures, indicators that will shine the brightest light on system failures and on system successes, so we know where to put future investments. And we need to know what's the best mix of funding, of investments, and incentives to drive all of these changes. As we work together toward an integration of public health and patient care into ongoing, sustained population health, what policy and implementation potholes do we need to avoid? Let me speak just briefly as I wrap up. I believe it's important to understand that, like public health agencies, hospitals come in all shapes and sizes with vastly different resources. We've started and grown according to many different factors and incentives, and hospitals exist within very different community contexts. I do believe that there's no, quote, typical hospital. So we must recognize that significant differences exist and build on that as an opportunity. Case in point, we are under, the tax-exempt portion of my membership is under new expectations from the IRS to do community health needs assessments, a good thing. We are to collaborate with others across the community, including public health, a good thing. But the fact is that the variety of circumstances and context means that we have to go about those in ways that are most appropriate in each community, which is a good thing, because we'll learn a lot more from all of those different experiments and trials and experiences, from which we can then identify down the road what works best. So we look forward to that collaboration, and we look forward to that experimentation to see how we can move forward together fastest and most effectively. So we have lots of challenges together. We have lots of opportunities. I think that we also have lots in common, not the least of which are the citizens of our respective service areas who look to both of us for leadership, for greater collaboration, for greater efficiency and more value on either their premium dollar or their taxed dollar. So I look forward to working more closely than ever before to getting rid of those bright lines to the extent they still exist, and to focus together on population health. So let me close by extending that welcome and that opportunity on behalf of the nation's 5,000 hospitals and health systems, so that together we can truly design a real continuum of services that best meet the needs of our communities. Together we can spot health anomalies at the community level. We can look at the maybe better utilization of resources across the community settings, and we can set about addressing them effectively together. We'll not only make the best use of limited resources, we'll save lives, improve lives, and improve whole communities. Thanks very much for listening. I look forward to more opportunities to work with you. Thanks very much.